Assalamu alaikum. Welcome back to Hilaal Live. Thanks for watching us on channel 347 on DSTV. You can also live stream www.hilaal.tv. Now, our next topic could be a bit sensitive to some viewers, and if you are a bit squirmish with the topic about eczema, you may want to turn away. We would never discourage you from tuning away from Hilaal TV, but this may be a bit sensitive for some of our viewers. And back in studio is our dermatologist, Dr Samina Parker. Assalamu alaikum.
Wa alaikum salam wa rahmatullahi wa barakatuh. How are you looking?
I'm very well, thanks. Thanks for coming back into studio. I'm glad that you're back. And we said last week that we will try and cover various topics surrounding our skin and our health care and the health of our skin as well. And one of the topics, and we call it atopic eczema. That's the medical phrase for it.
That's correct.
Tell us a bit more about what that is.
Sure.
How does the medical industry look at atopic eczema?
Sure. So the scientific name for it is actually atopic dermatitis, and dermatitis just means inflammation in the skin.
Okay.
And well, the layman's term is eczema. So atopic dermatitis or atopic eczema is actually, so the word atopy, it refers to a group of disorders where you are genetically predisposed to getting either eczema, asthma, or allergic rhinitis, which is hay fever.
Okay. All
Okay.
Right.
And it's the most common skin condition that, that affects patients of all ages. And I use 60% as a guide. So usually 60% of them present within that first year of life, and around 60% of them resolve by the age of 12.
Okay.
So it's mostly in the first 5 years of life that they present, especially in that first year. And it's a chronic, relapsing, inflammatory skin condition. Chronic meaning it's there for a long time.
Okay.
Relapsing obviously means that, the graph goes up and down. So there are times where it's completely under control, it's behaving, and then obviously you have some sort of trigger, and then it flares up again or gets out of control.
Okay.
And then inflammatory means that there's actually inflammation in the skin, and it's not an infection, it's not something that's contagious or that you can pass on from one person to another.
Because that's some of the misconceptions out there
Definitely.
when it comes to eczema.
Definitely.
But more importantly, it can be emotionally challenging as well, because if it flares up as you progress in your age, as you get older, and if it's visible as well on one's skin, then it can become a bit of a challenge mentally as well, and how you cope with everyday life.
Definitely. And I mean, especially when it's invisible areas, like you said, so the hands, the face, and I mean, that's how you interact with people. That's how people see you. It becomes a part of your identity, and it's definitely psychologically, challenging and distressing for patients.
Yeah. So what are the general causes of eczema? I mean, you've told us that it can present itself as young as, a child.
Yes.
And then could flare up later on in life as well.
Sure. So by far the main cause is genetics. So it's obviously a multifactorial complex disorder, and it's not one thing that causes it, but genetics is definitely a very strong factor. So around 90% of, patients that have early onset AD have either one or both parents that have atopic dermatitis or asthma or hay fever. And obviously if both parents have it, the risk is, much more increased. That's the first thing. And then where genetics is concerned, there's also a protein that's called filaggrin, which is a filament aggregating protein. I don't want to get into too much pathogenesis, too technical, but essentially, so it's a filament aggregating protein that is, broken down into natural moisturizing factors. And any loss of function mutations in that particular gene can obviously result in less filaggrin, less natural moisturizing factors, and of course more transepidermal water loss, and that leads to dry skin, more atopic skin. Then the other things that play a role in the cause are, of course, immune dysregulation, and we see that it's both the innate and adaptive immune systems that play a role and they interplay, and it's usually a T helper 2 response. Okay, and then the other causes I would say are epidermal barrier dysfunction. That's a very important cause. And I always use the analogy of, a brick wall. It works very nicely. Patients understand it, a brick wall that's around your house. So you want that brick wall to be nice and strong and intact. And as soon as you have the brick wall collapsing, so if the bricks are falling apart, if the cement is crumbling, you can have anything entering your home very easily. And of course, that's how things can leave the house also very easily. So the epidermal barrier functions as your brick wall. And, if there's any problem in that epidermal barrier, then of course you'll have transepidermal water loss, and vice versa. Any pathogens, any allergens, irritants can enter the skin and cause triggers or flares. And then the final thing I would say are changes in the skin's microbiome.
Okay.
So, there are organisms that live on our skin. They're part of our commensal flora. And the ideal environment is to obviously have a very diverse microbiome. So you want all sorts of organisms keeping each other in check. But as soon as you have over-colonization of one sort of bacteria or fungus or you name it, or virus, then obviously that will trigger a flare-up. And the most common one that we see is an organism called Staphylococcus aureus, which is found abundantly on our skin. It lives in our nasopharynx, it lives around our anus. So that's the organism that often, has overgrown in our skin, and that also triggers an immune response and causes atopic dermatitis flare-ups. So that's the causes in a nutshell.
Well, I mean, it's a lot to consider. And I would imagine that a consult would, last a little longer as you explain the different types of flare-ups that happened with eczema as well. And it's so sad to see that little ones, it starts from as little as babies all the way up into adulthood as well. What are the common, so if you look at all the different types of eczema or atopic eczema that you spoke about, I would imagine that each one has a different type of treatment of how to lessen the load, lessen the some of it is itchiness and, different causes. But what are some of the treatments that you would take your patients through?
Sure. So fortunately, all of the eczemas sort of have, similar ways of treating them. And atopic eczema in particular, so there are about 5 pillars of treatment. And obviously the first and most important pillar, I think, is to sit down with your patient, to counsel them extensively, explain what the diagnosis is, what it entails. It's nice to have, explain to the patients what's actually wrong so that they don't have unrealistic expectations. It's not nice to tell them that there's no cure for it, but there's definitely wonderful treatments out there that can certainly control the flare-ups and keep the eczema under control. So I try and do that on day one. And then I try and advise them about triggers that they can avoid, so potential triggers. And then, of course, the treatments. Because, the more time you spend explaining to them, the better adherence you get to treatment. Otherwise, you send them home with, a packet full of treatment and they don't really know. You haven't really empowered them to get on top of their own skin condition. So that's number one, educating the patient and counseling them adequately. Then I would say there are different factors that you have to address. So, you have to address the epidermal barrier dysfunction and then, of course, address the inflammation that's going on in the skin. And for the epidermal barrier dysfunction, we use soap substitutes. So nothing that has fragrance in it, nothing that has soaps in it, we use a soap substitute, okay? Things that don't make foam. And the best soap substitutes, I would say, that are easily acquired, even over the counter, are aqueous cream. Okay, and it's not a moisturizer. Disclaimer.
We use it very differently in the Cape.
Exactly. So it's got something called sodium lauryl sulfate in it, which is a preservative, and that's found in soap. That's why you don't leave aqueous cream on the skin. It might be an irritant. So you use it as a soap substitute. So you apply and you rinse off. And then the other soap substitute that we use is emulsifying ointment. So those address, obviously, the epidermal barrier. So you're not causing any further damage to that already disrupted epidermal barrier. Then the second and most important one, I would say, is moisturizers. Okay, or emollients, that's the other name for it. And the more you moisturize your skin liberally throughout the day, as often as you can, the less there will be a need for an anti-inflammatory medication. Okay, so that's like applying the cement to your brick wall. It's making it nice and strong and firm. So you moisturize, and we usually give cetomacrogol. And I mean, you get various companies out there that you can also get your hands on: Epimax, Epiderm, E45. There are so many.
Yes, yes.
And then I would say, to address the inflammation, we usually use, so the first line treatment is a topical corticosteroid. And the way we treat eczema is to try and treat it hard and fast. So we
Because
start,
you want that. You don't want it to
of course,
progress.
you want to get it under control as quickly as possible. So we use the strongest one or the most potent one. And as soon as you see a clinical response, you see the patient again at follow-up. As soon as it's better, we start weaning them down off it gradually.
Okay.
So we never stop abruptly, because what happens is, as soon as you withdraw the steroid abruptly, they get a rebound flare. So you go from very strong to medium, and then obviously to mild. And then once their skin has cleared, then we use what we call maintenance therapy, and that's a topical calcineurin inhibitor. So they do a similar job to steroids, but without all the side effects of steroids. Okay, so they also address the inflammation in the skin, sorry. And then just a couple of other things. I know I'm going very much in depth here. And then I would say, of course, if your optimal topical treatment hasn't worked, so things that you've applied to your skin, then of course we turn to medications that you drink. And those would be immunomodulators. We even use systemic corticosteroids, so prednisone. But saying that, I don't want people to think that that's the go-to. Exactly. It's not a cure, because what it does is it causes a dramatic improvement in the patient's skin. Patient thinks their eczema is curable, and then they often acquire the medication, from a friend or friendly local pharmacist.
Dr. Google. I got you. So we're going to take an ad break very quick.
Sure.
Lots of information, and I don't want our viewers to lose out on all this lovely information as well. Dr. Samina Parker is in studio chatting to us about atopic eczema. And if you've ever wondered how to handle this and some of the treatments, do stay tuned. We'll be back after the break. You are still watching Hilaal Live. Assalamu alaikum. Welcome back. Thanks for taking the time to watch us on channel 347 on DSTV, also on www.hilaal.tv. In studio, we're chatting about atopic eczema with Dr. Samina Parker, who's given us valuable information around this very pertinent topic. I do want to warn our sensitive viewers that it could be information that could be sensitive to some of our viewers, so maybe put the volume down or just take a break for a little bit until we end the slot. Doc, thanks so much for coming into studio.
Only a pleasure. Thank you for having me.
I'm learning so much about this, because it's one of those topics that you sort of see around, and you've heard about someone we know has had eczema, but we don't really delve into some of the reasons why this eczema flares up. And one of the reasons I want to ask is that often enough we hear that foods could play a major factor in having or picking up atopic eczema. Is that true?
So as far as food is concerned, eczema is not caused by food. Okay. I just want to say that loud and clear.
or the nutrients in food that could affect the body.
Yeah, so it's definitely not caused by food. If it were caused by food, I mean, it would make my job and my life a lot easier. If I could just tell patients, eliminate X from your diet and your eczema is cured. But that's not how easy it is. So it's definitely not caused by food, but it's definitely associated with allergies. Okay, so by that I mean, if there's anything, so let's just, put it in plain and simple terms. So the National Institute for Allergy and Infectious Diseases, the only time that they recommend that you test for food allergies, and that's also limited testing, in children under the age of 5 years who've got severe eczema, recalcitrant eczema that, is not responding to optimal treatment, is when, firstly, when it's not responding to optimal treatment, and then secondly, when there's a very good history of a specific food that's causing the allergy. So for example, they have peanuts and they break out into a rash, or their eczema gets much worse, significantly worse, and then we can obviously test for a peanut allergy. But it's very difficult to pinpoint a single food, and even the tests that we send patients for, they test about up to 30 things, and that can look at milk, cat hair, dog hair, grass, pollen, dust, etc., peanuts, soya beans. So if suppose it comes back and it says it's positive, your child is allergic to dust and pollen, there's no way on earth that you can ask a child to avoid dust and pollen.
course,
it's everywhere in
Correct.
the environment. You
Yeah.
can't really live in a bubble.
Right.
So it just provokes unnecessary anxiety in patients and parents. And the only time I tell them we'll test for food allergies is if there's a very good history of a specific trigger.
Gotcha. Another question I want to ask is that often enough we also hear that eczema could lead to something else, maybe a skin irritation or health problems.
Yes.
Is that also true?
So eczema definitely makes your skin more sensitive. Okay, you're more prone to sunburn. Okay, you're also more prone to obviously irritant contact dermatitis. Okay, so when you apply, let's say, perfume, okay, it can make you break out into a rash. Not all patients, but a lot of them.
I've heard of that, yeah.
Yes,
or
so
even jewelry for that matter.
Yes, absolutely. So, and then what was the other question? Sorry?
With regards to could it lead to something important,
Sure.
could be
So of course it can lead to depression, and I mean we see a lot of patients who have anxiety disorders, who have mood disorders related to their eczema, and that's because of the psychological impact it has on patients.
Okay, thanks for that very important information as well.
No
Speaking about sun irritation as well, does weather play a huge part in how our eczema flares up?
So in areas where there's less humidity, eczema definitely flares up. Okay.
Oh, okay. So just that, more than anything else, we're okay.
Yeah. That's why eczema flares up during winter.
It's more
Less
dry.
moisture in the air and more central heating being used. Air is very dry, so it makes the skin and mucous membranes dry.
Gotcha. Earlier on, you mentioned about some of the medication that's used when it comes to eczema. I mean, antibiotics and steroids.
Yes.
I think you mentioned prednisone as well.
That's correct.
That some people tend to run to as a solution.
Yes.
That's predominantly what's used to treat certain parts of your eczema, right?
Yes.
Okay, but it's not the solution.
Not the solution, definitely not. And the only time we use prednisone is when the eczema is severe, it's acute, and it's debilitating. Okay, so if let's say the patient has eczema that is extensive, so it's all over their body and it's weeping, they are raw areas, then of course we need prednisone. We need prednisone to get the acute flare under control. But I always tell patients that this is just a, temporary treatment, and it's only a short course of prednisone, maximum 5 days. It will get your eczema better, but it's not the cure for your eczema. And then as far as antibiotics are concerned, when the eczema becomes secondarily infected, so as I explained, the epidermal barrier is disrupted, and of course all sorts of bacteria can take advantage of that disruption in the barrier and cause an infection in the skin, and we call that a secondary or superimposed infection, and that's when we use, antibiotics. If there's any signs of infection, then we usually give them a course of antibiotics.
Okay, brilliant. One of the things you also mentioned earlier is about allergy testing as well.
Yes.
I mean, especially when it comes to eczema, is it necessary?
So as I mentioned earlier, the only time we do it is when, let's say the child is under the age of 5, they're on optimal treatment and they're not responding to, the best of treatments. And of course, if there's a very good history of a specific trigger or a specific food that's causing a rash or, the eczema to flare up, and then we can test for that specific thing.
Okay. Now, eczema can present and look like, and for those that don't work in the industry as well, it may look like ringworms, or it may look like psoriasis as well. The people often refer to your eczema as psoriasis. How do we differentiate between those?
Sure. So where psoriasis is concerned, so it's definitely a different age population that you're looking at. So eczema is mostly children, and then a very small percentage have it in adulthood, whereas psoriasis, it has a bimodal age distribution. So by that I mean it's patients that are young adolescents, so people that are, age 20 to 30, or patients that are age 50 to 60. So definitely different age distribution. And then the morphology of the lesions is much different to eczema. So eczema usually has ill-defined plaques. So it's red, scaly, By scaly, I mean, it's the peeling that you get.
Right.
And it's usually on the flexural surfaces. So that would mean your cubital fossa. So on the inside of your joints and behind your knees. Whereas psoriasis is on top of the joint. So we call it extensor surfaces. So it will be on the elbows and on the knees as opposed to behind the knees. And psoriasis also has a predilection for the scalp, has a predilection for the lower back area. It also likes to affect the nails and the joints. So we always, take the whole patient into account, examine them physically, also ask about joint symptoms. And then ringworms, how you can distinguish between that and eczema is ringworms also give you a well-defined plaque. So it's an erythematous plaque. So by plaque, we mean it's an elevated lesion. It's not something that's flat.
Right.
And it usually has active or raised edges. That's why we call it ringworms, because it looks like a ring. It's active at the edges. And then at the center usually looks clear, whereas eczema is more confluent. Okay.
Brilliant. I think that's amazing information, and I'm sure our community is learning so much
I hope so.
about all this information as well. For those that would like to get hold of you, that would like to come and consult, and maybe it's a very private thing, what are the best methods to do that?
So I think the best way would be we're available on Google. You can just Google the Dermatology and Hair Institute.
Okay.
And we practice in Brookdale Avenue in Pinelands. And then I'm also at Somerset West twice a week, and that's where I mostly operate or do procedural dermatology. And if you Google us, the contact details are there. If the lines are busy, then please send us a WhatsApp, and we always get back to you via WhatsApp.
Okay, fascinating. And I'm sure that, lots of our community are benefiting from your amazing work that you do as well. And what are your patient ages? Patient ages, as young as...
So it varies. That's why I love dermatology. It's fascinating because you get to treat from neonates to geriatrics to the elderly. At the moment, I would say I'm mostly seeing geriatric patients. And that's a lot of skin cancers, a lot of sun-induced skin damage. And then my second greatest population would be teenagers with acne vulgaris, with eczema. Yeah.
Okay, fascinating.
Very few pediatric patients. I would like that to increase, though.
Okay,
I love kids.
Inshallah.
Inshallah.
Jazakallah so much for coming into studio once again. We really appreciate it. I learned so much, and I'm sure our viewers learned just as much as well. All the very best, and we look forward to our next edition,
Thank you so much. Jazakallah khair for having me.
My absolute pleasure. Have a great evening. Assalamu alaikum.
Wa alaikum salam wa rahmatullahi wa barakatuh.
And that's Dr. Samina Parker, who joins us on a Tuesday, educating us about all things skin related. Today it was the turn of, we call it atopic eczema, around the treatment, the causes, and how you can live a better life as well. That's all we have for you on a Tuesday. We're back tomorrow between 5 and 6:30, inshallah, for another exciting edition of Hilaal Live. From the Cape Town team, Sohail Barnes and myself, Luqman Shadrack, have a lovely evening. Assalamu alaikum.